For that introduction, and I also want to thank the committee for the opportunity to be able to present to you this morning, and for you to get up and come over and attend this session. I know we're getting kind of into that part of the meeting where getting up earlier gets a little bit harder. As I thought about what to cover here, I took a look at the agenda, and I was very impressed early on with the content that we were going to hear at this meeting. And that agenda has not let me down. So far, it's been a very interesting meeting, and I hope that I can add to that content in a small way. By disclosure, obviously, I do work for LivaNova. I'm an engineer by training, not a clinician. So nothing that I talk about is intended to be clinical advice, and also use every device that you use, whether it's ours or not, within the cleared indications for use, and as you see fit with your physicians. There are a number of people I need to acknowledge as contributors to this presentation. Three fantastic colleagues that I have a chance to work with on a daily basis that I owe a lot to, and I couldn't be here and sharing this information with you. And it's Shanna, who's sitting here in the front row, Allison Gerlach, who's not with us at another meeting, and then Sarah is a part of our medical affairs division and helps me on that side of things. Also need to acknowledge a couple clinicians that have been very influential for me. George Justison at the University of Colorado, who's done a lot of the pioneering clinical applications work in goal-directed perfusion, along with Charles Yarnell at Jefferson Health. He's presented at this meeting a couple of times. And then also Bob Groom, who recently retired from Maine Medical. They've all contributed significantly to my ability to be here and share this information, so I wanted to acknowledge them. The title of the talk is Inspired Perfusion. How many of you thought that was going to be just about an oxygenator? Okay, I'm going to not totally disappoint you, but it is going to go a little bit broader scope than that. We're getting to the part of the meeting where, at least for me, if you've attended these sessions, my head's getting a little full. There have been some really great presentations here. Dr. Scott challenged us on some of the paradigms around mechanical ventilation. And can we do a better job with ECLS instead of forcing air into the lungs? Dr. Bartlett reviewed some basic, but I think very critical pieces of knowledge around gas transfer and how it really works on a functional level. And then Dr. Conrad gave us that information in equation form and looked at the effects of recirculation and how we manage perfusion flow. The Shark Tank was an incredibly interesting exchange of information. Again, I want to thank the planning committee for having an event like that, and I hope that continues and the participation grows. Yesterday, Jeff Riley went through periods of expansion and contraction in perfusion, and the sky is falling. And what he really told us is it's not falling. We have a very strong platform in what we do with extracorporeal circulation. It's met a couple of threats, but we've responded to those by upping our game and continuing to be relevant. And I think extracorporeal circulation is probably more relevant and has a brighter future than at any point in its history. And then yesterday, Dr. Shackelford and soon to be Dr. Fitzgerald put in the human element around what we do. It's not just about devices and technology, but the teams and the people that get involved. So I put all that together and look for signs of inspiration, and all of that is actually very inspiring because of the way we can have an effect on patient outcomes. Now, the definition of inspiring is the process of being mentally stimulated to do or feel something, especially related to creativity. So we have a chance to be inspired when we're working in this field that has a chance to reach so many different patients. Mental stimulation, though, it's a constant process. It doesn't stop. How many of you have had a new inspiration in the last year that changed the course of your career? Maybe in the last month. Bill, you have to see a few hands. Maybe in the last month, or maybe last night you had an idea. You woke up in the middle of the night and you had a vision for how you might do something different. That's all inspiration, and hopefully it goes on all of the time. As we look back at the development of oxygenation, it is filled with stories of inspiration. From the first oxygenator that Dr. Gibbon developed, and then advancing into the rotating disc oxygenators, and then the first of many iterations on membrane devices. All of the people that contributed to that were inspired to improve patient care. Now, we live in a day and age when you want to be able to pull up your phone and find a piece of information very quickly or solve a problem. I think if you go back and look at a timeline on this, we can put some of that in perspective. There were many, many careers that were entirely dedicated to just the advancement of those 3 versions of the oxygenator. Hundreds of papers were written, many, many books by researchers and scientists. Most of us will never know their names, but they all contributed to get us to where we are today. This last year at the American Academy of Cardiovascular Perfusion meeting, I had a chance to listen to 2 really amazing lectures. The first one was the Charles Reed lecture, which Dr. Bartlett gave. And I don't know whether the Academy is going to be able to post that online, but if you have a chance, I'd encourage you to go back and listen to that lecture. A phenomenal review of the day-to-day challenges from Dr. Bartlett's personal experience on how inspiration led him and his team and his colleagues to advance perfusion and ECLS therapy. And then the next one was the Thomas Wharton Memorial Lecture by Kevin Charette. Kevin had a chance to go back and look at all the things he's been able to do over his career because he's a perfusionist. And he repeated that saying multiple times. And it spanned things from his education to mission trips that he got to go on to help treat patients that otherwise would not have been treated. Again, I draw inspiration from both of these gentlemen and the work that they've done, along with many of you that I've had a chance to work with over the years. The group from Children's of Philadelphia published in 2016 an overview of notable events in the development of pediatric oxygenators. And the print's a little bit small, I apologize for that, but it spans nearly 175 years of development to get us to where we are today. So as we think about when is the next innovation coming and why does it take so long, we put it into this time scope and we realize the pace of advancement really has picked up compared to what it was then. From LivaNova's point of view, we've done a lot of work to advance the design of oxygenators. This is a list of oxygenators that LivaNova and its predecessor companies have been involved in going back to 1980. I'll ask for a show of hands of who's run devices on this list. Just curious. Quite a few. I won't ask you to identify which models or which years because that kind of puts you into those buckets that Tony Shackelford was talking about yesterday. But from that experience, we looked at which ones worked really well, maybe which ones didn't, and decided we needed yet another one on this list. And that started a development process. We also looked at what was going on in research around how do we improve outcomes for patients. And there were a number of different topics that were of prime concern. One of the first ones that came up was the negative effects of hemodilution on bypass. And Habib published a paper that really, I think, became a landmark paper. It drove almost overnight people to call us and say, I want to make my tubing pack smaller. How can you help me do that? We also looked at gaseous microemboli and lipid emboli through the work of Dr. Stump and Gerard Myers and a number of other people, and we identified that with neurocognitive deficits that were occurring in bypass. These reached the lay press in a couple of different articles around titles of pump head, things like that, and it got a lot of attention in things that we needed to do to try to improve our game. Biocompatibility also became an issue. We developed biocompatible coatings back in the late 1990s. They quickly became the standard of care in the US, but biocompatibility really goes beyond a coating. It goes into the design of the devices and how they're run clinically. And a number of different papers point us to things that we can do to improve that. Now, a lot of people think about the different coatings that are available. Those have also advanced from the early coatings made from heparin to now physiologic-like systems that duplicate the outer wall of a cell membrane and reduce that reaction. We've also found ways to make oxygenators more efficient by able to reduce the surface area so that the overall exposure is actually reduced. And that was one of our objectives in that next oxygenator that we were working on. Over the course of about a 10-year period, I was involved in projects along with an engineering team and a number of other people to reduce gaseous emboli that passed through the perfusion circuit. A number of different papers came out by Philip de Sommer, a number of other people that looked at the mechanics of how do we manage air inside the perfusion circuit. About that same time, Bob Groom was doing work in his OR up at Maine Medical, putting cameras around the OR and Doppler systems on both the circuit and on patients' brains, and trying to tie different events that happened during the case to when they would see an increase in gaseous microemboli. About the time Bob was finishing up that work, I ran into him at a meeting in Vancouver, and we had a side conversation about the work I was doing on reservoir design, and he said, as soon as that's released, can you send me one? So I sent him up more than one, sent him up a number. He included it in his study, and we were able to get that dramatic reduction that you see on the right through a combination of what he was doing in the OR and the way we modified the reservoir design to decrease the size of the filter in the venous reservoir. So again, some inspiration there that filtered into device development, changes in practice, and improving patient care. So in this backdrop, we began that project of how do we come up with yet another oxygenator that raises the bar and does a better job. And that, if you've not been involved in a development project, is quite challenging. First part of my career was spent on that side of the business, and I had a chance to do a couple of those. But I wanted to share with you some of the behind-the-scenes information that goes into that. It starts off with you have to define the big picture things that you want to change with this new design. We were able to identify 4 of those. The first one was around blood conservation. We didn't want to just make the circuit small, but we wanted to have appropriate use of the volume that's in the circuit. So everything that was going on in the circuit and that blood was going through was value added. The next thing we wanted to do was improve biocompatibility. And as I said, that's more than just a coating. It has to do with the fluid mechanics of how blood flows through the oxygenator, the filters, the reservoirs, to not stimulate the clotting cascade further through mechanical stress, air interface, foreign surfaces, a number of different things. Then we picked up on that theme of embolization from Dr. Stump and the work Bob Groom had done, and we said we wanted to reduce emboli to enhance patient protection. And then finally, we wanted to improve perfusion practices. So how do perfusionists interact with the devices? How do they set them up most efficiently? How do they do that in an error-free or error-reduced way? How do we solve common problems with interaction with the devices? Those became the big things that we wanted to accomplish. Now, the reality is I can't just hand this list to our engineering team and say, go do this. They want us to write things that are called product requirements. Those are very specific so that the engineers that don't interact clinically can understand what we need, and they can have a chance to creatively then come up with a design, perhaps new, that meets those requirements. In the process of developing Inspire, there were close to 250 different specific requirements written, things around this is the number of quarter-inch ports we need, and this is the orientation, and this will be the barb design that we need. Or instead of barb design, we may say, we want the tubing to go onto the barb easily, but yet be able to handle this much pulling force once it's put on. And then it's up to the engineers to figure out what is the design of that product that then delivers it. Now, they go through a lot of work. They have some really cool tools to use today that the earlier developers of those oxygenators didn't have, in that they can almost completely create a new oxygenator without ever making it real. It's all virtual. And they can do mathematical modeling around that. They can optimize the design. So they looked at a couple of different designs for oxygenators. This is one that was considered, obviously didn't make the final cut, but it just shows you some of the detail that they can do with these tools. Then they can model the flow paths as blood, gas, and water flow through these devices. They can look for issues around assembly and the forming of the parts in molds, a number of different things that they can look at before they ever make a real prototype. But real prototypes do come. Now we've got 3D printing that allows us to do amazing things much faster than in the early days when these parts maybe had to be carved out of a solid chunk of plastic, and one of them would take weeks to produce. Great advantages and strides forward on that side of the development cycle. And we made hundreds of these in terms of prototypes and then taking them into the lab and evaluating them. We put all those characteristics that we had to have up on a board, and then we test the prototypes against them. How did we do? Not all of them work out. In fact, in this chart, a majority of these did not achieve the full objectives. So then it's back to the drawing board, repeat the cycle until you get a winning design. The entire process is now defined by development processes that meet FDA requirements and other regulatory body requirements in how the design is validated, developed, at what point all the characteristics are frozen, and then you move on to finalizing and testing it. It goes through what we call phase gates, to where there's requirements to get through each gate, and the project stops if you don't meet all of those requirements. And you can imagine when you've got a team of, say, 35 or 40 engineers all wanting to say, I did my part, but the guy down the road, his part isn't working, the rest of the team puts a lot of pressure to say, let's turn that red one green. But it becomes an interesting and a challenging project that you work through. Once we get to that stage, then we go through and start doing review around flow processing and risk management and where could potential failure modes occur. We rank all of those failure modes by probability and severity so that we know if something were to occur, what is the effect of it. That may get us through a phase gate, or it may say we go back and we start over again. And both of those happened over the course of that project. Finally, when we have a workable design, we began putting it into the lab and really putting it through its paces and showing it to people for the first time. And this is where we begin to get that actual feedback of what does it look like, how does it feel, does it meet the original expectations. Quite a number of different things that we look at there. Again, all very interesting. You're really hopeful that it turns out positive, but it doesn't always. The result of all of that effort was the Inspire Oxygenator, which became a new family, 2 different reservoir designs, the option to have an integrated filter or not, and then 2 different oxygenator sizes in the 6 and the 8. But our work wasn't done yet at that point. Now we go out and we do a market assessment study where we run hundreds of these oxygenators in clinical settings all over the world to make sure we didn't miss anything and all of the expectations of our future users were met. In the case of the Inspire, we went to 70 centers in the European Union and intercontinental regions, 20 centers in the US, and we targeted to run close to 2,000 oxygenators in that market assessment study before we commercialized the device. We did commercialize it, and in 2013, the Inspire Oxygenator was added to this long list, and we were very proud to release that. The engineers were very relieved when we got to that point. It was a cause for a great deal of celebration, as you might know. And then it began into the hands of the experts that put it through its paces and tried to decide, does this really pass clinical muster? Over the next couple of years, a number of papers were written on the performance of the Inspire that validated it against neurologic protection, blood transfusions, reduction in kidney injury, a number of different aspects that were then reviewed by some of the best minds in the world, and they decided to publish papers around it. And we were fortunate that we did pretty well in that way as well. Early last year, we celebrated a milestone with the Inspire of crossing 1 million clinical uses since the global launch in 2013. In the first year, we sold over 100,000, and then it grew quickly from there. By February of 2017, out of all of the oxygenators sold by LivaNova, 90% of them were the Inspire. So I think we did a pretty good job there, and we have now crossed the threshold of over 1.4 million being run as of the beginning of this year. So we had a little cake and a little celebration, but our work is not done. The challenge to improve outcomes, it continues. Yesterday there was some reference in Jeff's talk to the Partner 3 trial, which compared the results of using TAVR to SAVR in a pretty dramatic way. And I'm sure that some of you, along with me, were concerned about that result. And what does that mean for bypass? And is it going to reduce the number of cases that we have? And the results were good. If you or a loved one or I needed to have a valve replacement, I would certainly consider TAVR as an alternative, even though I have so much experience and confidence in the surgical approach. Where it's appropriate, it makes a lot of sense. But it's not appropriate in all cases. I don't see it as a large threat to replace extracorporeal therapies. Instead, I look at it and say it's a challenge to us as device providers and you as clinicians to see if there's ways we can improve our outcome, improve our game, if you will. Because now we have a measurement around comparing 2 different therapies that I think raises that bar. So, I'm sorry, I didn't catch up with the slide here. So with that Partner 3 trial, they looked at 1,000 low-risk patients. They were randomized to TAVR or SAVR. The primary endpoint was death, stroke, or rehospitalization, and they nearly cut that in half on TAVR compared to SAVR, and a very significant reduction in length of stay. So very important in terms of that achievement. On the other side, the challenges I would give to us as a community, both the people on the vendor side, the device development side, and the clinician side, is we can improve our game. We can do that by paying attention to the details of what we do and how we do it. We talked yesterday about standards and guidelines that are being developed to identify best practices and be more consistent in how we do things, which if we can drive out that variation following Six Sigma techniques, we can identify what causes outliers. Are they really appropriate? Should standards be changed to adopt to those outliers, or something be changed with what led to the outlier? And then analysis of those best practices in detailed ways. We saw a number of different papers over the course of the last year that look at statistics around perfusion practices. And then finally, the pursuit of improvements. And it's easy for, if there's two sides, the vendor side and the clinician side, to point to the other and say, well, you go fix it. So we accept that challenge from you, and we're looking for ways to improve the devices that we provide and the technologies in order to be able to do that. And we hope that you will join us in perhaps considering changes to clinical technique to adopt those technologies and give us feedback on how we can improve. So I want to suggest with the rest of this talk some areas that LivaNova is working in to try to help you improve outcomes. The first one is in electronic versus paper medical records. Electronic medical records are in 94% of U.S. hospitals today. They're used by almost all departments in the hospital, except they're not dominant in perfusion. A majority of perfusionists today are still using paper. When you use a paper chart, you do capture relevant information, but it's captured in discrete time periods that are often separated by 10 or 15 minutes, and it misses a lot of information. If you want to go back and review those cases, here's a list of questions that you might ask. Can you derive that information from your paper record? And oftentimes you cannot. I reviewed 4 paper charts this week as a part of investigations that I'm involved in, and I came out with more questions than I did answers. And in one case that I was able to look at an electronic record, all that information was readily available that I needed. We've developed a system that allows you to capture trace information from the devices that you use. And this is one of the problems that came up in one of the investigations I was doing this week. We couldn't get to the individual identification number of an oxygenator. We've developed a simple way to transfer that information from your tubing pack via an RFID reader that automatically populates all of that information about each device in your tubing pack, and it does it without transcription error into your electronic medical record. That then gets loaded into the record where we can go back and look at it later if we need to, or you can if you want to do analysis around what types of devices were you using, perhaps ask some other questions. We've also developed an electronic charting system that can capture an enormous amount of information from your pump and from other devices in the OR to help you do a better job managing that case and recording it. This is information from Charles Yarnell. He presented here a couple years ago on the Connect system and goal-directed perfusion, and he pointed out that there could be 45 different pieces of information that need to be recorded at the same time. You may be good at writing, but you can't write that fast, and if it's my writing, you can't read it. Connect has the ability to capture 675 times that information in 15 minutes. The biggest thing it allows you to do is to focus on the patient, not the paper. And as was pointed out yesterday, these systems are quickly becoming safety devices, not just systems that create records for case reporting afterwards. To quote Charles Yarnell again, he came up with a great one that I really like. Paper and pumping is like texting and driving, which is, of course, something I hope that you don't do. Taking a look at the management of perfusion cases, Gordon Defoe published a paper quite a while back now, 2001, that showed the negative effects of lower hematocrit on bypass. This also fed into the work that Habib did, that published his paper as well. And that, again, looked at all these different negative things associated with hemodilution. That led to an era of development, a new round of inspiration of what I'll call mini bypass. A number of different oxygenators were developed to really miniaturize the circuit. We also saw the introduction of wrap and ap techniques, or what I call prime volume displacement, which became very common. How many perfusionists in the room today do some sort of prime volume displacement technique in your priming? So it's almost become universal. You've adopted your circuit designs and your techniques for this, and this again came out of this work. The mini bypass oxygenator design era was really interesting. It started with a company called Corex that developed a really small oxygenator, 1.1 square meters, and it was able to support a patient without a reservoir and became reservoirless bypass. Each of the major companies then came up with circuits that were similar to that, brought in new clinical techniques, but it really became trying to learn to drive backwards through your rearview mirror, because without a reservoir, now what you do with the pump becomes opposite of what you do with an open system. It taught us a lot of things that could be optimized, but it didn't do it in an optimal way. That led to another generation of devices from all the manufacturers that actually ended up with less priming volume than the mini bypass systems in many cases, and it was safer and easier to run. Despite all of that work, we still have problems in outcomes in bypass. This is a synopsis of a number of papers that was put together in 2012 that shows some of the issues that happen, again, when hematocrits drop. And this was still in the era of trying to minimize bypass, and at the time, doing all we thought we could do to manage that. There was some work that was done in Spain to look at kidney injury and the deleterious effects of that on patients, and what they found in situations where postoperative renal replacement therapy was needed, patient care and outcomes were significantly affected to the point of increased charges, longer length of stay, compromised kidney function. Dr. Ranucci published some, again, landmark work about that same time frame that supported the idea that we needed high hematocrits, but we were missing part of the picture. And that was in how much oxygen are we delivering. DO2 is now something that's talked about at almost every meeting. But at the time this work was done, we were more focused on PO2 as an indicator of are we transferring enough oxygen. So what Dr. Ranucci pointed out was if you have a high hematocrit and a high delivered oxygen, in terms of renal replacement therapy, those patients do the best. The next group was a little bit of a surprise in that if you had a low hematocrit, but you maintained oxygen delivery, these patients only fared slightly worse. And then the real conundrum came, if you had a high hematocrit, but you weren't keeping your eye on total delivered oxygen, those patients fared far worse. And then finally, low crits and low DO2 was the worst of this group that he looked at. That work was followed up and validated by Philip de Sommer from the University of Belgium in Ghent, who came up with a little bit different guidelines than Dr. Ranucci, but together they were developing this concept of goal-directed perfusion. And what Professor de Sommer was able to do was identify a level of delivered oxygen that if he stayed above that, he was able to get a 65% reduction in acute kidney injury. The other thing that was interesting was he added to this by looking at the CO2 side of the respiratory equation, and if you could maintain O2 and CO2 in proper balance, you could keep your patient in an aerobic metabolic state, and that also would avoid kidney injury because the root of the kidney injury issue became lack of oxygen that led to anaerobic metabolism. So what Professor de Sommer was able to give us was a guideline around O2 and CO2 that we could monitor as a metabolic status indicator. We then developed that into the Connect GDP monitor, which is a module inside our Connect data management system where you can track all of these variables and you can customize the way it's set up. So you can look at trends of DO2. You can look at oxygen extraction ratio. You can look at O2 and CO2 ratios and set this up in a way that's meaningful and useful to you. Dr. Ranucci went on to conduct a multi-center randomized controlled trial that was published and presented in 2017 on the effectiveness of this goal-directed perfusion concept. He was actually able to show superiority of the GDP program halfway through his study population, so the trial concluded early and it showed this benefit. And what he found there was, particularly in Aiken stage 1 kidney injury, he saw a dramatic reduction. Now in stage 2 and 3 is isolated, it was about equivalent, and then in looking at all cases, again, he got a significant reduction. Now this is not the final work to be done in this field. There were some limitations in this study that need to be addressed, and it probably needs to be expanded, and I believe that work is going on now. We'll continue to see publications around goal-directed perfusion and kidney injury, I think, as we attend meetings in the future. When working with a number of different clinicians that have adopted this, they've also brought some new interesting ideas as well. Again, this is from Charles Yarnall and the way they're set up at Abington with how they use the Connect monitor. And you'll see that the Connect monitor sits right on their pump. That's great. The perfusionist can see what's going on. But they've also tied that screen into a large monitor in the OR so the rest of the surgical team can share that data too. And as was talked about yesterday, ECMO and perfusion are team sports. So what they're able to do now is train the rest of the people in the OR to what they're looking at on that Connect screen. And the surgeon now can be aware of perhaps something that's going on at the table that's affecting venous return, that's now dropping oxygen delivery. So now this data becomes used by the entire team, and it's shared, and then they do debriefs around it afterwards. Another area that has been an interest of mine is how do we manage cardiotomy suction blood? I first became interested in this segment of perfusion, this aspect of it, when biocompatible coatings came out in the late 90s. And people were talking about, I have to have a coated circuit because it improves XYZ, whether that's platelet adhesion, white cell adhesion, blood loss aspects. The thing that we found out in doing that work with coatings is how you manage suction blood is just as important as a coated circuit. Going back and looking at the literature, there's a large number of articles that support special management of suction blood in a perfusion circuit as having advantages. Some of these go back all the way to the 1970s. So not really new information, but certainly quite a number of articles. When we worked on the Inspire, we developed a second version of a reservoir that allows you to sequester cardiotomy suction with the Inspire Dual. And the way that works is there's a chamber in the back that the suction blood can be routed to, and then you can decide, do I need to reinfuse that, or can I process it, or in the case of it's watery irrigant that simply came back in the pump suckers, perhaps I just want to discard it. So that came out with the Avant Oxygenator first. Saw some adoption in the US, but more so in Europe, and the way it was designed more closely simulated a venous bag reservoir. Just curious, how many people in the room have ever run a venous bag? Oh, we got a few hands up, all right. So that had a bottom entry, just like a venous bag does, but in a hard show world and in the need for vacuum-assisted venous drainage, that reservoir didn't really reach a lot of success in the US. But we took that concept and changed it to build it into the Inspire reservoir so that now you do have this option of sequestering blood to the back of the reservoir. Now, has there been any recent work published around the benefits of suction sequestration? That was one of the questions that I started to ask myself after we launched the Inspire. And the answer is yes. In 2013, a group out of the Netherlands took a look at retransfusion of cardiotomy suction blood and its effect on hemostasis. And they did both ex vivo and in vivo studies. And what they found was the addition of 10 to 20% of the patient's blood volume was able to be tied to reductions in platelet aggregability and clot stability. Now, if you had small amounts, they did not see those decreases. So small amount of suction blood were not a problem here. But when it became in that 10 to 20% range, they were able to find some significant differences. That same group went on to look at the effect on pro and anti-inflammatory cytokines after cardiac surgery. And they were able to track that as well and find the differences that could be attributed to how that suction blood was managed. Another group looked at lung injury associated with bypass, and this is a fairly recent paper written by Gerwin Ingalls, and he did this at the University Medical Center in Groningen. And here he looked at suction blood and how it contains cytokines, different neutrophilic proteases, lipids that are associated with lung injury, and they tried to measure those. And his specialty is in biomarkers, so he brought some new tools to this discussion that he was developing in another project and applied it to this question as a part of a larger study on autologous blood salvage. So he looked at 195 patients and he compared where there was cardiotomy suction reinfused and where it was sequestered and processed, divided those roughly equally, and he looked at variables of post-op ventilation time, allogeneic blood exposure, a number of inflammatory markers, and then also lung injury markers. And what he found was in the group where blood was sequestered, ventilation time was significantly shortened from 10 to 12 hours. Significant difference there. Allogeneic blood transfusions were significantly reduced. There were really no differences for postoperative morbidity, ICU, or hospital stay in that study, but he did find some differences in inflammatory markers that were interesting, and also in lung injury markers. So his conclusion from this paper is that with cell salvage, there is less lung injury, there is less alveolar capillary injury, and there's shortened ventilation time. All of which could feed into that bigger challenge of ours of how do we improve those overall results from SAVR. Another group that looked at this variable was from Japan, and they looked at the differences between closed and mini circuits. So again, picking up on some of that earlier work that was done after Dr. Habib challenged us to reduce hemodilution. And they compared three combinations that I found to be very interesting. The first one was an open venous reservoir that contained cardiotomy suction, or we'll call a traditional circuit, open venous reservoir without cardiotomy suction, and then one of the mini bypass circuits. And the intention of this was to isolate what were the contributing effects of each of these reservoir types on the outcomes. And what they found was that cardiotomy suction was the leading cause of some coagulation disorders in terms of thrombin generation and significant thrombin antithrombin elevation. Open reservoirs, however, did not contribute in the sense that heparin was effectively able to block that side of the clotting cascade. And it raised some interesting questions on how we use heparin dosing with or without cardiotomy suction. Could heparin management possibly be changed? They found nearly identical results in the platelet group, and I was particularly surprised by that because I've been a fan of closed systems as reducing air interface. I always consider air to be a foreign surface, and it potentially could activate platelets. Well, between these reservoirs, they did not see that difference, so I found that to be interesting. They did find that the suction blood, there's a limit to how much can be beneficial when it's sequestered. I think you've run into that if you've tried to be a strict adherent to sequestering suction blood, and it's probably in that 10 to 30% patient volume range of where you get the best benefit. Shifting gears just a little bit and looking at the evolution of care outside of the cardiac OR, LivaNova is in a great position to observe this with the acquisition of Tandem Life, a fantastic addition to our portfolio, and they've been able to open up some avenues for us to look at how do we expand our scope and contribution. As we look at different patients that could be treated in extracorporeal modalities, we look at the intra-aortic balloon pump, which has really been a standard of care. Today it treats about 45,000 patients a year. Mechanical ventilation, a topic at this meeting, also a standard care in respiratory therapy, treats about 120,000 patients a year. Old technology that, as Dr. Scott pointed out, dates back to the iron lung and concepts of forcing air into a patient's lung to really solve a blood problem through the lungs. Ventricular support, whether it's LV or RV, is growing in terms of application. About 30,000 patients are treated a year with that. We've got some really interesting and successful devices from Abiomed and some other companies. And then there's this expanding area that we've all been involved in, probably for a number of years, depending on your practice, in what we'll call extracorporeal life support, or ECLS. And it is kind of a catch-all that covers cardiac and respiratory and has the ability to treat a number of different conditions. From the Tandem Life platform, we actually have 4 different products that can fit into this space. Tandem Heart traditionally fits into that mechanical circulatory support space. The Protect Duo cannula is an innovative way to access patients' blood and return it that reduces recirculation and can enhance patient mobility and perhaps comfort, which can lead to some interesting outcome improvements as well, and that's an area being studied as well. Tandem Lung adds respiration to this equation, not in the sense of full bypass, the way we do in the cardiac OR, but in a supportive way that can help us treat more patients early in a disease process. Again, something that was discussed by Dr. Scott and others yesterday. And then Tandem Life puts all of these components together in a kit that we think can reach patients earlier and more conveniently and more safely in different ways that's not available today. Now, our approach to this is a little bit different than perhaps the way perfusionists would approach this, in that we want to reduce the complexity around the deployment of this technology so that it can be used in more places. That also allows us to focus more on the patient rather than the circuit and the technology. So I'm going to close with a couple of things that I hope are inspirational as we put all of these patients that could be treated by extracorporeal technology into one bucket. In the US, that adds up almost to 2 million patients a year. In the cardiovascular space, in the OR, we estimate that's around 270,000. So you can get a sense of where this opportunity comes from. The disease states that are tied to this are varied. This means that perfusion is going to have to become an expert in more than just things that happen in the cardiac OR. Lots of different challenges coming into our treatment scope. We probably all know somebody at a personal level that's been affected by one of these, or you've certainly had them come through your hospital. The reality is a very, very small number of patients are actually receiving the treatments that these technologies can provide. So that becomes our challenge, to work with you as a vendor partner and your clinical teams to help treat more patients in more places, whether it's through cardiopulmonary bypass in the OR or treatments that occur outside the OR using some of these new technologies. The other thing that I think was really a reminder to me through Dr. Bartlett's presentation was that we're going to do this one patient at a time. And when Dr. Bartlett first took that big step to try this experimental ECMO technique, he didn't know how it was going to turn out. He knew how it would turn out if he didn't try. So he was willing to have the courage to take that step, and we all got to experience that result in a very personal and profound way, at least for me, to be able to see the result of that work a number of years ago. So you think about what you're doing today, the decisions you make. You may think about, how does it affect my case when I go home or next week? But think about 10, 20 years from now. The new things you may be willing to adopt and try, what effect will that have on our profession and our ability to treat these patients? So my inspiration to you is to invite you to collaborate. Work with each other. Work with us. Let's share information, share data. The Shark Tank event, again, I want to applaud the organizers for doing that. That was one of the best exchanges of ideas that I've seen in a long time. So with that, I hope I've inspired you to enjoy the rest of your day, and I want to thank you for your attention.